We are now turning away from squamous cell carcinoma into adenocarcinomas, and we have a panel with Professor Shah, Professor Hess, who is from Hamburg and Director of Voice and Speech Department, Professor K.Kian from MD Anderson in Houston, and Professor Miljenko Bura from Zagreb. And we have about half an hour to our disposal now, and I'll try to cover some of the fields that you have introduced. First, you cover the surgery very well. You mentioned in a sentence that there is also radiotherapy, and the question is, which is the place for radiotherapy in treatment of differentiated and undifferentiated cancer?
You have the words expert.
Yes. There was, while radiotherapy is used very sparingly, so in selected cases, we do not treat many patients. And if you can turn on the slides, and I guess a picture is better to illustrate. So this is used in adjuvant setting, and rarely after the first surgery. It's usually after recurrence. And in cases as shown here, you can see on the left side, as Dr. Shah showed, tumors involving the larynx and resulting in either positive or closed margins. These are another examples of recurrence tumor. And as you can see here, there is a pattern that recurrence tend to occur in the tracheoesophageal groove, where the surgeons really cannot take a big margins without injuring the recurrence laryngeal nerve or esophagus and so on. And in these cases, now the technique of radiation is really better than in the previous decade. And here is an example that you can really map out where the gross disease were and shape your target volume accordingly and deliver the highest dose to where the closed or positive margin is and lower dose to where the lymph node have been affected. And in addition to that, we really pay attention to spare, whenever possible, even the submandibular glands on one side so that the patient would not have xerostomia at all. And with this type of treatment, you can see even in recurrence diseases with tumors as big as we have shown and mostly poorly differentiated, the local regional control rate is quite good. Now, there is no level 1 evidence here. There has not been a randomized trial, but given the fact that these tumors have recurred before, I think this curve is pretty decent, and the predominant pattern of relapse is distant metastasis. So I think the take-home message is in poor prognostic factor patients, it can be used really to prevent local regional recurrence. And if you are going to do it, you really need to pay attention to the technique, has a quality assurance program, and commenting on earlier discussion on late effects of radiation, it really depends very much on the technology. And when we implemented IMRT within the RTOG, we did a credentialing program. And in fact, 1/3 of the centers did not even pass the physics credentialing, let alone target volume delineation. So this is a really learning process. So I'll stop there. Thank you.
I suppose this was a recurrence of differentiated tumors?
Yes, but they tend to be less differentiated when they recur in that volume, and Dr. Shah has commented on that issue already.
But when we have the purely anaplastic tumor, we never cure the cases.
No,
but it's important to achieve local control. What's the role of radiotherapy?
Unfortunately, these are usually big tumors, And even with radiation, local control rate is still pretty poor. Yeah, so we are still looking for something else. And perhaps there are two drugs that are now having pretty promising data. That is the RET inhibitor Amgen 706 and ZD6474, so it's inhibitors of VEGF and EGFR and also other kinases that has produced a pretty impressive response rate in patients with metastatic disease.
Yeah. So another question, do you think this kind of radiotherapy should be centralized? How many cases are you going to treat a year?
Yeah,
to get good
not many. I think it needs to be done in an experience center. And the quality control procedures has been outlined for radiotherapy. So I think if a center needs to do this, they can really learn. We generated atlases that has been posted in the web page, and they can really, any center can now request to undergo dosimetric testing, and we can even check the target volumes online, which is being applied in all RTOG trials.
Thank you. We discussed, yes?
Yeah. Can I add? According to the anaplastic cancer, unfortunately, we have to say that it isn't a surgical disease, but we heard that the other modality is with really poor results.
Yeah, not working either.
Yeah.
Yes.
Let's then turn to the surgical technique. You showed the broad field, wide open, good access, but today there is a discussion about minimal invasive surgery, robotic surgery, and endoscopic surgery of the thyroid. And that might have implications on the complications as well. I wonder if you could comment on that.
Well, complications will increase with increasing volume of the disease and decreasing experience of the operating surgeon. So the young inexperienced surgeon will have more complications, and the advanced disease with extensive local invasion will have, I won't use the word complications, but sequela of treatment, implying recurrent nerve paralysis, difficulty in swallowing, particularly if you have resected a portion of the esophagus, and the long-term sequela of neck dissection. But looking into the overall picture of head and neck cancers we treat, thyroid cancer is a very happy disease to treat. You're talking about patients, majority of the patients whom we are going to cure and make them happy. The ones that you are not going to be able to cure require new drugs, as you rightfully pointed out, either tyrosine kinase inhibitors or even VEGF inhibitors are in clinical trial. But we don't have yet a final word to say that this is what we should use. All the systemic agents are still in phase 1 type of trials.
Professor Bura?
I think that we can just agree with Jatin that we are happy because the increasing number of the low-risk patients in the thyroid, and there are big difference according to the 20 years ago. When I started with the thyroid surgery, I was dealing frequently with big nodules, big cancer. But now, last years, I can say that mostly I'm dealing with the cancer less than 1 centimeter, also less than 2 centimeter. It is really rare that we have 4 centimeter papillary carcinoma. It is a big change in conception of treatment, I think, but we are going very slowly. I'm talking about my country and also many parts of Europe. It is important to point out that, and also according to that fact, I think that it is necessary to think about younger and younger people who are included in that population with the cancer. We also have younger and younger patients with small microcarcinoma. What to do in that situation? Because of that reason, I started with minimally invasive surgery. You know that the minimally invasive video-assisted surgery in thyroid started about 10 years, 1908 in Pisa and Rome by Micoli and Bellantone, and it is well done in many places, also in Germany. I started 1.5 years before, and one of the reasons for that was small cancer, microcarcinoma, very young people. And at the beginning, I was doubt about that. I heard a lot of that, and I was suspicious because of that. But I tried to put all facts in one place and think I have to do that on with the same results as I do with open surgery. If I can do that, I can perform that procedure. And maybe we can show first slide. Yes, it is just for illustration and to see how it is. It looks skin on the incision on the skin, and also instruments, and finally scar on the neck. It is totally invisible, and we can start with the movie. I have to explain that it isn't endoscopical procedure. It is a big difference. In this MIVAT procedure, the endoscopical procedure is about 20% of time. The rest at the beginning, at the end of the operation, is the normal open procedure under controlling of eyes. And I think that it isn't so difficult for the ENT surgeon, specially trained in the endoscopical sinus surgery. Now you see sometimes it is important to cut the muscle to reach the upper pole. That is a time where you need assistance of camera and assistance of screen. In this moment, we open that area of the upper pole, and we are preparing very carefully, like in the normal surgical procedure. It is important to point out we control all steps during the operation. We are controlling the important structures which are very important in the thyroid gland surgery. Now here are the upper vessels, and we divide that with special instruments very precisely, I think. And one of the conditions when I started is that I have to perform the procedure. Here is the superior laryngeal nerve, that it is necessary to perform the procedure with the same surgical results. Otherwise, for me as a surgeon, it isn't acceptable. Here is the upper vessels, and it is necessary to do under the vision through the optic, and after that, it depends of skills. Many of that procedure, after that, we can continue as an open procedure. With this,